Great. It looks like we are live. We are in the second to the last session of today's micronutrient workshop. I think this is our sixth one from today so far. And I have Mary Beth Augustine, who is our lead clinical educator here today. And she's actually going to cover a topic that is probably one of the most important of the day. And that is kind of like the basics of how to assess and interpret micronutrient testing. I think that's probably one of the most commonly asked questions is, well, what does this mean? And so she's actually going to walk us through that. She is obviously, as one of our clinical educators, you may have already spoken to her before if you have made use of our service that we provide with clinical education for providers. But she is a registered dietitian and a fellow of the Academy of Nutrition and Dietetics, as well as a delegate in the Academy House of Delegates. Her past work experience includes 21 years practicing integrative medicine in 3 different teaching hospitals in the New York City area, as well as cardiovascular research at the American Health Foundation. She has some speaking highlights, including the United Nations Committee on Aging, American Institute for Cancer Research, Cancer Survivor Conference, of which she is a cancer survivor, as well as the Integrative Healthcare Symposium, the Food Nutrition Conference and Expo, and the Hawaii, Massachusetts, Nebraska, New Hampshire, New York, West Virginia, and Wisconsin Academy of Nutrition and Dietetics meetings. So she is really, a wealth of information in our own internal clinical team, as well as outside of Vibrant, all of the just vast experience that she brings to the field here and to this topic today. So I am going to ask that you guys type your questions in just as all of the other sessions before. Type your questions into the Q&A and we will cover those at the end. We should have 10 to 15 minutes or so before the next session starts. So if you have any questions, go ahead and type them in and we'll get to them when we're done. And welcome, Mary Beth. I'm going to go ahead and turn it over to you.
Super. Thanks so much for that warm welcome, Sarah. Now I feel like I have to impress, my goodness.
You always do. It's not hard for you.
Well, thank you. So today I'm excited to speak to you about foundational skills for assessment and interpretation. I have really grown to love our Vibrant America Micronutrient 3.0 test. I think it's just such a wealth of information. And sometimes if you're a beginner to using it, it can almost be overwhelming. I usually tell providers that after interpreting about 24 of these tests, you can do it in your sleep. But initially it's a lot of information because you have 2 measurements for most micronutrients. So on the test itself, you end up with 84 results, if I recall correctly. So, it's a lot of data points to kind of, assess and interpret and really find, the meaningful use. So without further ado, let's dive right in. I'd be remiss if I didn't take a second to kind of just discuss laboratory diagnostics. Very often we are asked, what does this mean? Just by looking at the results without having any history. And I really like to say that laboratory diagnostics, you have to consider 2 different things. The laboratory science, which is very black and white. I mean, it's very quantitative. Everything is, the parameters that we look at test performance to see if the tests are accurate, precise, reliable, and reproducible, just very, very kind of black and white. Laboratory interpretation, on the other hand, really is 50 shades of gray. You could give the same test results to 20 different providers, whether it's thyroid function test results, lipid panel, a inflammatory panel, micronutrient test. You give the same exact results to 20 or 30 different providers, you'll get at least a good 15 different diagnoses and certainly 15 different treatment plans. And depending upon the provider, 15 different fees for services, but that's another story. So the concept of it's open to interpretation is really literal. So I discourage people from thinking just too black and white when they evaluate their micronutrient test, I really encourage them to kind of look for the gray. So laboratory diagnostics, you always need clinical correlation. You can't just look at the test results alone in a vacuum. You really need to come to a diagnosis. You know, you have to take into account the past medical history, the past surgical history, the family history, diet history, weight history, social history. You want to know about their, you know, social stressors and their life events, medications, supplements. You also want to have a good understanding of their signs and symptoms. You want to do a physical exam. And in addition to lab tests, there may be other procedures that may, you know, lead you to a diagnosis. So while we, you know, have placed tremendous value on laboratory diagnostics, they really are just one tool in your diagnostic toolbox, and they always require clinical correlation. I want to talk a little bit about the advantages of getting a direct quantitative measurement of micronutrients in serum, white blood cell, and red blood cell. So there are other laboratories that do micronutrient testing that are not getting a direct measurement, a direct quantitative measurement. They may look at things like cellular growth in cell culture medium, and you know, as far as Vibrin, what we're actually doing is we are literally, we're getting a quantitative measurement of the micronutrients in serum. We are lysing the white blood cells and getting a measurement of the micronutrients in the white blood cell. We're not looking at white blood cell growth, and we're looking at the micronutrients in the red blood cell membrane. So there are definitely, you know, disadvantages to testing micronutrients in cell culture. That can include cell culture really tries to mimic the in vivo environment. However, cell culture growth medium micronutrient concentrations may not in fact reflect normal physiological levels. Additionally, cell viability research is still needed, and then genomic stability research is still needed. So this is a nice paper if you're interested in doing some more reading on the influence of micronutrients in cell culture, you know, on cell viability and genomic stability. I love that we measure serum and red blood cell micronutrients. I think there's tremendous advantage to having that in conjunction with the white blood cell micronutrients. Serum and red blood cell micronutrients, you've really got a good, I want to say at least 70 years of data, you know, extensive population data where serum and red blood cell have been validated in healthy populations. Also different biological sexes, different ages and stages of the life cycle. So there's tremendous amount of studies on serum and red blood cell micronutrients in, you know, age-matched pediatrics, in infants, in children, in adolescents, in pregnant women, in lactating women, in older adults. So these research studies on serum and red blood cell micronutrients have really built a foundation that can help us, you know, understand the validity of the reference ranges in serum and red blood cell in the population. There's also been serum and red blood cell micronutrients have also been validated in many ethnic and racial populations, although admittedly research disparities do still exist. Also, they've been validated in different disease states. All of the studies that have looked at micronutrients in liver disease, in kidney disease, in you know, Crohn's disease, ulcerative colitis, cardiovascular disease, cancer, they've all used serum or red blood cell or plasma micronutrients. So, you know, tremendous amount of data. They've also, serum and red blood cells also been validated in many, if not most or all of the functional genetic polymorphism studies. So there's definitely a, while we place a tremendous value on the white blood cell micronutrient testing and definitely look towards future research continuing to build that white blood cell micronutrient clinical utility, right now, most of the studies that are done are really have been done in serum and red blood cell. with regards to different disease states, and including all of your functional genetic polymorphism studies, looking at MTHFR, vitamin D receptor, glutathione selenium transferase, FUT2, et cetera. So I just think there's a tremendous advantage to having serum and red blood cell micronutrient measurements for comparison to your white blood cell micronutrients. And last but not least, especially in people who may have low or high white blood cell counts. So Vibrant does report total lymphocyte, neutrophil, and white blood cell counts. And I think that's critically important. Essentially, any laboratory that measures intracellular micronutrients should be reporting total cell counts. There is, a kind of advantage and critical need to being understanding if what the micronutrient levels of the white blood cell really are reflecting normal physiological status. And so there are many things that can affect your lymphocyte and your neutrophil and your white blood cell counts. So let's think about, bacterial infections. How much of your patient population are you working with that have bacterial or viral or fungal infections that may affect the neutrophil count or the lymphocyte count? Inflammation may affect the neutrophil count, physiological stress, rigorous exercise, smoking, pregnancy. As far as lymphocytes, similarly, acute viral infections, think about how many patients you're working with acute or recurrent or reactivation of cytomegalovirus, Epstein-Barr virus. So there's so many factors that can influence the neutrophils and the lymphocytes, not to mention autoimmune disorders, looking at either high or low neutrophils and lymphocytes. And again, how much of our patient population that we work with have autoimmune disorders. So it's critical really to know that when you're measuring white blood cell micronutrients that the levels are normal. And if not, how do you interpret the test in that regard? And I'm happy that Vibrant does report on total neutrophil and lymphocyte counts and total white blood cell counts. A number of conditions can affect the monocytes, the eosinophils, and the basophils, although admittedly they're a much smaller percentage of white blood cells, which is why we don't report on them. You're really getting about close to 90% of your white blood cells made up by neutrophils and lymphocytes. So again, we do report those counts. So I'd say about 10 to 15% of the time you may find a report that has high or low white blood cell, neutrophil or lymphocyte counts. And in that instance, I always say, get on the phone with clinical the first time you encounter it so that we can walk you through with our, second set of eyes on it to offer you an interpretation. I also think there's a tremendous advantage. I know other laboratories don't routinely report on micronutrient overload or toxicity. Some laboratories, they just report micronutrients in the context of are they deficient, borderline, or normal? And really then you're only looking at part of the picture because there can be harms from micronutrient overload or toxicity. So we want to know what is borderline high. We want to know what is high. And if you, again, just thinking about normal physiological levels, there are certain micronutrients that have a much, much narrower range, physiological range. Think about many of your minerals. And they also have a narrower toxicity range. So again, I'm really happy that Vibrant reports highs has an upper cutoff for almost every one of the micronutrients on our test. So that's something to take into account. Another thing when we talk about kind of the black and white versus the gray of micronutrient test interpretation, taking into account kind of conditional variables that you want to, really understand if this test really reflects your client or your patient's normative status or their true value. because we don't always want to base our clinical decision making on just one measurement at one time. We don't know if this measurement really is the norm for the person. Is this the norm for John Doe or Jane Smith? So there have been studies of intra-individual variability in micronutrient status. So this was a nice study that they essentially did serial micronutrient measurements every 4 months. And then they looked back and for some micronutrients, and they were measuring 25 micronutrients. And for some micronutrients, they had as many as 21 measurements over time for some of the subjects. And what they found was when they, assessed each individual, if you had only one micronutrient measurement for that person, one vitamin A level for Jane Doe, it was in no way predictive of their normative or true value. However, if you had 2 to 3 measurements, you had about 80% of the person's true value. It was predictive of about 80% of the person's true value or their normative status. If you have 4 or more measurements, then you really can achieve about 90% of the true value. And for me, this was kind of a light bulb moment. And I I looked at it in the context of macronutrients. And I just thought of myself from a protein perspective, just because if I track my diet on a Monday, I get 56 grams of protein. That doesn't mean that's my normative value. On a Tuesday, I could get 112 grams. On a Wednesday, I could get 94 grams. Thursday, I might get 78 grams. So it makes sense that the more measurements you have for a person, the more likely you're going to be identifying their true value or their normative status. Interestingly, in this study, what they found was that high levels may require more measurements than low levels, which makes sense. Again, the little light bulb for me was, oh, well, that makes sense because high levels are often more kind of outliers, right? Let's just think about, the standard American. What do we know about micronutrient status? They tend to be undernourished, not overnourished. So it just kind of makes good common sense that higher levels may require more measurements to really ascertain that you're really looking at that person's, true value or normative status. So just to kind of recap, 2 to 3 measurements equals about 80% of the person's true value. 4 or more measurements equals about 90% of the person's true value as far as kind of predicting it. And when on the micronutrient test, you've got serum and white blood cell or serum or red blood cell. For almost all of our micronutrients, we have 2 measures. There are definitely a few where we only have 1. But right there, you're looking at micronutrients at 2 different points in time based on serum or cellular levels. So you've already got 2 measurements there. So simply by, you can assume that this is, predictive of 80% of their true value if you have 2 measurements. And then by repeating the test, you're getting up to 4 measurements. So, take home point, retest, especially if you have, a micronutrient that you're really concerned is playing a role in their, functional well-being, or if you have, a very high level that might indicate some type of toxicity risk, then you definitely want to retest. So let's talk a little bit about the physiologic variables that can impact micronutrients, primarily fasting, inflammation, renal function, and pregnancy, although liver function can certainly influence micronutrient status. And I know you've had some great speakers today, so I'm not going to give the deepest dive into this. And I'm assuming everyone who's here with us today has some, baseline level of understanding of micronutrient status, although we're all always at different levels of knowledge and skill. So this is just meant to be kind of a brief overview. Interestingly, the National Health and Nutrition Examination Survey, NHANES, I want to say since 1998, they've been doing micronutrient testing on a subsample of the population that they survey. So for those survey respondents, a subsample of them, they actually collect blood and urine, and they measure many micronutrients in blood, a few in urine, like urinary iodine. And interestingly, in the NHANES survey that they do, the subsample that they do a specimen collection on, they also test for heavy metals and environmental toxins and pesticide residues. So it always impresses me that, an NIH-funded study is really looking at, environmental toxins and heavy metal toxicity and pesticide concentrations. So lots of good population data in that regard. So this was a study that really explored many of the physiologic variables that can impact micronutrient biomarkers. And the number one really is fasting status. And for what they differentiate is, greater than 8 hours versus 3 hours. Of these physiological variables impacting micronutrient status, and there's certainly more. There's obesity, there's smoking, vaping, body mass index. I mean, there are a number of variables that can be assessed. But in this, for fasting, they looked at greater than 8 hours of fasting or less than 3 hours. And all of the variables they assessed, they considered it a small to moderate effect size on in either elevating or lowering the levels. But what they found was if you were fasting for greater than 8 hours, you will see higher levels of homocysteine as compared to 3 hours, higher levels of serum amino acids, omega-3 fatty acids and omega-6 fatty acids. And actually, I see this is a little error right there. That serum amino acid should actually be in the other column. So fasting actually fasting for greater than hours, you will have, I'm sorry, I'm confusing myself. If you are fasting, you will have, you will see, fasting for 8 hours, you will see, oh wow, now I'm really confusing myself, 1 second. If you're fasting for greater than 8 hours, you should expect to see higher homocysteine, higher serum omega-3 fatty acids, higher serum omega-6 fatty acids, and higher, okay, now I'm throwing myself off here. I'm going to move on, and I think I just reversed my arrows, and I'm going to come back to this one. For inflammation, you can see higher levels of iron indicators, omega-6 fatty acids, folate, red blood cell folate, and ferritin. And with lower inflammation, you can see lower folate serum with the CRP less than 5. You can see a lower folate serum, a lower vitamin A, a lower B6, a lower vitamin C, a lower vitamin D25 hydroxy, and lower omega-3 fatty acids. So the key cutoff seems to be that C-reactive protein of 5. And then for renal function, they look at kidney disease stages 1 to 5. And if you have chronic kidney disease stages 3 to 5, you'd expect to see higher levels of vitamin A and B6, higher levels of serum, higher serum folate and red blood cell folate, higher levels of B12, methylmalonic acid, homocysteine, and vitamin E. And if you have chronic kidney disease stage 1, 2, interestingly, you'll actually see lower levels of vitamin A and B6. So even there, you have variability depending upon earlier stage chronic kidney disease or later stage chronic kidney disease, even for the same micronutrients. And you'll also see lower levels of vitamin C and 25-hydroxy-D. And then in pregnancy, you can expect to see lower levels of vitamin A, B12, methylmalonic acid, homocysteine, iron, and ferritin, and higher levels of serum folate, red blood cell folate, vitamin C, 25-hydroxy vitamin D, vitamin E, and then omega-3 and omega-6 fatty acids and red blood cell. So see, these are just a few of the variables that can impact micronutrient status. Of course, it goes without saying, and I'm sure many of the other speakers addressed, GI absorption. This, as the saying goes, you are what you absorb. So we definitely recommend the gut zoomer. You do have micronutrient absorption all throughout the small intestine, and even in the large intestine, you have micronutrients that are impacted, like vitamin K, biotin, sodium, chloride, potassium, water, of course. So just consider all throughout, from the stomach all the way to the large intestine. You're going to see, so someone who has a peptic ulcer disease, a gastric ulcer disease, someone who has, small intestinal bacterial overgrowth, you can see, different micronutrient levels depending upon where the dysfunction is in their GI tract. The micronutrient dial charts on the test, I just want to mention it. I know some of the speakers earlier today did present, kind of their preference in using the micronutrient dial charts or not. I think, different people respond to information differently as far as, the graphical reporting. I think it's nice that we have grouped the micronutrients according to their body system or structure and function. There's definitely a few patient misperceptions or client misperceptions that often need to be addressed with these micronutrient dial charts. One thing that is not automatically intuitive to patients is that the micronutrients that are included in each of these body systems, structure or function, the laboratory has assigned a different weightage to each of the micronutrients depending upon how significant a role it plays in that body system or structure or function. So in cardiovascular health, for example, an EPA would have a higher weightage than like a vitamin A. And for bone, joint, and muscle health, calcium or a vitamin D or a vitamin K or magnesium would be rated higher than an iron or a glutamine. So for each of these dial charts, there is a different weightage assigned to the nutrient based on its importance and in the structure or function. So, and I think that's helpful to educate patients with regards to that, because sometimes, the misperception is, oh, I only have one abnormality here, and my score is lower than another area where I have 2 or 3 abnormalities. The other common misperception is that a high score equals health or a low score equals disease. So we'll very frequently hear, I have, my patient has SIBO, or, I have osteoporosis or fibromyalgia, and my gastrointestinal barrier score is 100 and my bone, joint, and muscle score is 100. And what we just want to do is we want to reframe the education around that and say, well, good news. Right now, if you've got 100 in your gastrointestinal barrier score, it's telling us that the micronutrients that you need for a healthy gastrointestinal barrier and structure and function, you have those micronutrients. They're normal. There may be something else contributing to your SIBO. Could be that you use, proton pump inhibitors for, antacid suppression for a long time. Or it could be that you have an acquired pancreatic enzyme insufficiency or deficiency. Similarly, for bone, joint, and muscle health, we could say, well, your score is 100, even though you have osteoporosis, it might be your hormone status that is a hormonal imbalance that is contributing to your osteoporosis, or inflammation, or you're not doing enough weight-bearing exercise. So again, just kind of sometimes correcting the misperception that I can't possibly have 100 if I have a disease process in that body system. I'd be more concerned if someone had SIBO and osteoporosis and their score was, their gastrointestinal barrier score was a 56 and their bone, joint, and muscle health score was a 77. Then I could say, oh, well, micronutrient status is contributing to the severity of your osteoporosis and your SIBO. So sometimes it's just nice to reassure them that even if they have a positive or a high micronutrient dial chart score, that's great. It tells us it's not contributing to the severity of your condition at this time. So just again, reminding them that micronutrient status really is just one factor in each body system and functioning. And there can be, many multifactorial causes that would influence, health and disease. So with regards to the abnormal results, I spend about a minute and a half on this page. And I say that because patients tend to really get hung up on this page here because it tells you what is frankly abnormal. And really, this doesn't tell us anything about what's optimal, what's borderline low or borderline high. It's a nice summary of what's abnormal. On this page, I encourage providers to look for 3 patterns just to help inform the assessment and interpretation of results for the rest of the test. It is a nice way to, at a glance, really inform your thinking for the rest of the test. So the first pattern to look for is there a pattern of abnormalities by blood compartment, meaning are there more serum or more intracellular abnormalities? And here, clearly, you can see there are more serum abnormalities. So right away, that gets me thinking, just at a glance, this first page, I wonder if there was something that may have really impacted their most recent micronutrient status. They've got more serum abnormalities. The second thing I look for, and we'll definitely dive deeper into that in the next few slides, but the second pattern I look for really is a directionality of the abnormal results. Do we see more highs? Do we see more lows? Do we see a mixture of both? And here, clearly, there's another pattern. You've got 8 abnormalities and they're all deficiencies, all lows. So pattern 2 identified. And then the third pattern I look at really is the abnormal micronutrients themselves. So really, after looking at the directionality of the results, then I want to look at the micronutrients and see, is there a pattern? Are we seeing, B vitamin abnormalities? Are we seeing fat soluble vitamin abnormalities? Are we seeing a pattern for mineral abnormalities or antioxidant abnormalities or amino acid or fatty acid abnormalities? And here, okay, well, I do see, we've got a few amino acids here, that are abnormal. We've got a few minerals that are abnormal. So again, this can kind of inform my thinking for the rest of the test. And again, just, this is really just looking at what's grossly abnormal, this page, either high or low. And again, it really doesn't tell us anything about borderline low, borderline high, or desirable or optimal. But it definitely helps clue me in because, for example, if I see something like mineral abnormalities, or say I saw B vitamin abnormalities, say it was B1, B2, B3, B5, were low, I'd be thinking, did this person have a recent all in serum? Did this person have a recent urinary tract infection? Did they have, recent diarrhea with watery losses of, water soluble micronutrients? Did they maybe do some recent endurance exercise? Are they on a, gluten-free, dairy-free, grain-free diet? So right away, I can just start thinking, once I identify a pattern, it's going to inform my thinking for assessing the rest of the test, When looking at serum white blood cell and red blood cell micronutrient status, it's really critical to look at the date of service on the test. It sounds obvious, but because you may be seeing, it could be 7 to 14 day turnaround time for the test. You're busy, they're busy. You may not be seeing them till 6 weeks after the test. It's quite common. So what you really want to, I feel this test is really best interpreted with the client present or the patient present, so that you really have this great history to help you interpret it. And so you want to just start thinking right away in the week before the test, the month before the test, and the 3 months before the test, understanding, did your patient change their diet? Did they change their exercise regimen? Did they initiate, discontinue, or change their dose of a medication? Did they initiate, discontinue, or change the dose of supplements? Did they experience a life event, a trauma, or a change in their stress level? Again, thinking, oh, wow, this might really, if they've had a stress level, this may really change in their stress level. It may influence their antioxidants. If they've had, a surgical trauma, this may affect their micronutrients for, wound healing. So just really understand if they've had a life event, their, mother-in-law fell down the stairs and moved in with them, it may have influenced their ability to, consume their meal, their, typical diet now that they're acting more in a caregiver role, again, it may have influenced, the oxidative stress they may have. Also, you want to understand, did they, in the week, the month, or the 3 months before the date of service, did they have an acute illness, infection, injury, or surgery? Or did they experience a worsening of a chronic illness, infection, or injury? So again, really understanding, interpreting this test with the patient or the client present, I feel is always the best. Because otherwise you're just trying to, assess the micronutrients kind of in a vacuum, if you will. And it's not always pathology related. It certainly can be. It's not always, genetic polymorphism. It certainly can be. But there's so many other factors that we want to take into account. When you have abnormal results, or when you're comparing agreement and disagreement between compartments, you really want to kind of ask yourself 6 questions in assessing. The first question is, well, what is the intake of micronutrient from all sources, from your diet and from supplements? So what is the intake? The second, are there losses of the micronutrient? What are the losses of this micronutrient, either from the gastrointestinal tract or the urinary tract or skin? And again, having that understanding, did they have that recent, infection? I can't tell you how many times, we're reviewing these test results. And it's like, oh yeah, they look back at the date of service and, oh yeah, that's right. I did have I had a urinary tract infection, or, oh, I swam in a lake and swam in an algae bloom lake. This was a interesting one. Someone reported her serum micronutrients had looked, like poster child. They were all very desirable, but her white blood cell micronutrients were all in the tank. And when I asked her to look back at the date of service, before I started thinking some type of pathology, like maybe she's not, transporting her micronutrients into the cell. I said, just look back at your calendar, look back in your phone and tell me what was going on. And it was about 2 months from the date of the service. And she said, oh, that's right. About 3 weeks before she had, 3 weeks before the date of the service, she'd swam in a lake with a big algae bloom on it, thought nothing of it. She was an avid hiker, outdoor enthusiast, rock climbing, hiking, camping, horseback riding, grew up on a farm. So to her, she's going to swim in a lake, algae bloom or not. But she did, the next day, she got violently ill, high fevers, vomiting, diarrhea, couldn't hold down any food for like 2 weeks, lost 15 pounds in 2 weeks. And when she was looking at her calendar, she said, that's right. The serum levels really coincided with like the week she was recovering. Like she'd recovered, and she said she'd gained 5 pounds back because she was, eating so well, and, that 15-pound loss. So, there are definitely, the micronutrient test can tell a story. And you really want your patient or your client, to be sharing in that narrative. I have similar examples where, serum levels look great, white blood cell levels look terrible. And before I start thinking it's intracellular transport and uptake, or genetic polymorphisms, getting that history, and it's like, oh, so you were a maid of honor in your best friend's wedding, or, I had I'll give you one more example before we move on, but this one was interesting. It was, test was done at the end of April, like the last week of April. We saw the patient, I want to say it was, June, early June or something. And again, here, the serum levels looked far, far better than the white blood cell levels and the red blood cell levels. And so in getting that history, it turns out, I said, you did this test last week of April, going back a few weeks when we're looking at your white blood cell, can you tell me, did you have, any life event, illness, et cetera? And he says, oh, he said, I'm an accountant. He said, in the 3 months before tax day, I make 90% of my income for the year. And in the 2 weeks before tax day, he said, I don't eat, I don't sleep, I don't, I don't drink, I don't urinate. He's like, I am glued to my desk, 16 to 20 hours a day. So, again, this was purely a lifestyle, correlation there. So you always want to understand really, what is the intake of the micronutrient from all sources? Are there losses of the micronutrient from the GI tract, urine, or skin? Is there a reason you might have increased utilization of micronutrients? Are you an athlete? And I know, you had an excellent presentation earlier today on athletes and nutrition, so I won't, get too much into that, but, maybe they have increased utilization of their B vitamins or their antioxidants because they, just did a half marathon on the weekend, and we're looking, you look at the data service, it was, a Wednesday, and the weekend before, they did a half marathon, and you see, oh, all of their B vitamins are depleted, their antioxidants are depleted. It makes sense. So understanding, might there be increased utilization of micronutrients, whether it's, B vitamins for over consuming alcohol, glutathione or selenium, or, under, tremendously, increased stress. So why might you have increased utilization? You also want to consider, could there be drug-induced micronutrient depletions, oral contraceptives and B vitamins and magnesium and zinc and vitamin C, et cetera, folate. What medications might be causing drug-induced nutrient depletions. And then really, once you've kind of gone through those, for very common reasons for micronutrient abnormalities, then you can start to consider, is there a reason that you might, if you're seeing normal serum levels and abnormal intracellular levels, is there, some reason that intracellular transport and uptake might be impaired? And if we think about that lipid layer around our cells, right? All of our cells have that nice, beautiful fatty lipid layer. Well, it could be subject to, oxidative stress. So you want to rule out lipid peroxidation, inflammation, toxins that could be impacting membrane permeability. And then you also want to consider, could there be genetic polymorphisms? So I usually try to rule out the first 4 factors before I, consider that this might be an intracellular transport or uptake, impairment, or could it be a genetic polymorphism? And when we consider micronutrient overload and toxicity, you will definitely see patterns where very often you've got agreement between both compartments, right? So like here for vitamin B6, you've got, agreement, both serum and white blood cell, they're suboptimal. It's around the 20th percentile or a little less. Very commonly you will see agreement between the 2 compartments, but it's also not uncommon to see some degree of disagreement, and sometimes total disagreement. Like if we look at vitamin B5 down here, we'll see, in serum, it's midpoint of the range. And in white blood cell, it's borderline low, maybe around the 5th percentile. Now, this is clear disagreement. And sometimes you'll see even stronger disagreement. One's borderline low, one's borderline high. What do you do in that instance? With disagreements between compartments, most often I say base your supplementation decision-making on toxicity risk. Most providers will base supplementation either on the white blood cell level or the red blood cell level, because it does reflect longer-term micronutrient status. So if you have a low micronutrient level in your white blood cells or red blood cells, most often we'd say supplement. However, if you've got disagreement and you've got a high serum, we might not want you to supplement. We might want, recommend getting a second measurement, because especially if it's a micronutrient that could pose a toxicity risk. So we do often recommend repeating a measurement for micronutrients with toxicity risk. Think about your, B6 and neuropathy, many of your, metalloid metals, your zinc, your copper, your manganese, your chromium, your selenium. Again, these have narrower ranges of toxicity. So for something like pantothenic acid, say you had a high serum and a low white blood cell, we go, oh, very little toxicity to pantothenic acid. So, you certainly could supplement to, raise the level without risk of harm. And for most of your lab values, it usually goes without saying that most often you want to be kind of midpoint of the range, maybe somewhere between, that 40th to 60th percentile in that range. And very often a good argument could be made for having it at 70th to the 80th percentile. Say, it's pandemic and you want to have your vitamin C and zinc and vitamin D up at the 80th percentile, that is okay. But typically for me, when I see micronutrients getting above that 80th percentile, then I'm more concerned about overload and toxicity. This was an example of a B12 that was 1283. We want to ask, is this from oral supplementation? Are they doing B12 injections? Could there be B12 related gene polymorphisms? And there can be harms from a B12 that's, too high. I definitely think it's a, underappreciated clinical concern. And it's fairly frequent, it's kind of frequent and underestimated anomaly, we'll say. A high B12 can indicate a functional deficiency or a qualitative B12 deficiency. Even if you have, of course, we always want to recommend MMA. And there is a great paper on, did I include it here? Oh, I have a nice paper on MMA gene polymorphisms along with B12 gene polymorphisms. You want to, for high levels of B12, you want to rule out kidney and liver disease, any hematological abnormalities, and, more concerningly, solid neoplasms, hematological malignancies. I spent a few years working at Memorial Sloan Kettering Cancer in New York City. I'm a cancer survivor of a lymphoma. So, you want to consider hematological malignancies as well. Most often it's going to be due to supplementation, but sometimes it just deserves further workup. You want to rule out genetic variants that alter B12 status by affecting the proteins involved in B12 absorption, cellular uptake, and intracellular metabolism. So I always, I am concerned when I see a high B12, and I often recommend further workup, or at the very least, just understanding, obviously, is this just due to supplementation? And sometimes, as you know, patients aren't the best historians. There are a number of B12 gene polymorphisms. This was an interesting study published in 2018. Based on 16 international studies, and they identified 59 different B12 gene polymorphisms. Definitely ethnic associations are involved, and interestingly, more research is needed on non-Caucasian populations, although that's kind of true with a lot of health disparities. A lot of the research is done on Caucasian populations. But SNPs, there are a number of B12 SNPs that can result in either lower or higher B12. This here is not a list that's not all inclusive. Vibrant does not test for these SNPs, but again, the first thing you do is rule out that this is, B12 supplementation. Consider any of the, kind of hematological risks, and then consider, working up any of the B12 gene polymorphisms. B6 probably is the one, micronutrient that's the most known for that U-shaped curve, harms at the lower level and harms at the higher level. And definitely, at both ends of the spectrum of that curve, you can see, hematological, dermatological, cardiovascular, gastrointestinal, and neurological harms. So, we definitely, B6 is one that we want that to be midpoint of the range, not borderline low or borderline high. Vitamin D, often we have questions on the vitamin D, what is seemingly what patients may perceive as discrepant results. They don't understand how you can have, a high serum D3 and yet a low white blood cell D3 with a strong 25 hydroxy D. And I will say this is a pretty familiar pattern. In this context, you really want to assess vitamin D, all sources of vitamin D. You want to assess the sun, the skin, food and supplements, and then consider liver hydroxylation, kidney hydroxylation, and vitamin D receptor gene mutation. Just kind of to refresh your memory, vitamin D is kind of photochemically produced in the skin from the sun, in the form of 7-dehydrocholesterol. And then you take into account your dietary sources of vitamin D, D2 and D3. And then you have hydroxylation by the kidney of all of those vitamin D sources. So vitamin D from, sun, food, supplements. You have hydroxylation by the liver. And then you have 25-hydroxy D, which is your inactive vitamin D. And then you have hydroxylation by the kidney to the active form of vitamin D, 125-hydroxy D. And then you have, kind of at the cellular level now, you have either genomic action or non-genomic action, either, hold on. Either in the membrane vitamin D receptor or the nuclear vitamin D receptor. So that's where you have the kind of biological functions of vitamin D after it binds to those vitamin D receptors in the tissues and the cells. So this is a very common pattern, and usually we would just tell the patient that, well, clearly you took your vitamin D, like they'll say, I am taking vitamin D 2,000 IU or 5,000 IU. And I say, well, clearly you took, you took it that morning, and or you've been taking it recently, and we see it in your serum. You have adequate levels in serum 25-hydroxy D after hydroxylation by the liver, but you have low levels in the white blood cell. So, we could consider doing like a vitamin D receptor test, or we would just ask about other sources of, we really want to understand other sources of vitamin D, vitamin D2, sun exposure, really understanding all of those sources. So from food, from diet, from supplements, and from skin. You certainly can. Other laboratories do run like a fractionated vitamin D2. We do not, or 125-hydroxy vitamin D. But then you could look at the full picture of vitamin D metabolism, including vitamin D receptor, mutations. Vitamin D toxicity can occur. It's not, it's less common, but we do see from time to time, vitamin D up in the 108, 120, 130. This was one case of it, 137.9. The most common cause really is, vitamin D, exogenous vitamin D supplementation. But there are also other causes like increased number of vitamin D receptors, saturation of vitamin D binding protein, increased activity of 1-alpha hydroxylase or decreased activity of 24-hydroxylase. You can also see it in granulomatous disorders and some lymphomas. And for the latter three, that's when you'll really see the increased concentration of 125-hydroxy D, which we do not measure. Again, which is why sometimes when you have a high vitamin D, you want to measure all of the forms of vitamin D, including D2 and 125-hydroxy D. So, but I think this is a great snapshot of vitamin D metabolism overall that's going to be suitable for most of our patients. I wanted to highlight vitamin K1 and K2, kind of assessment and interpretation between the two compartments and the two conversion of K1 to K2. I mean, dietary intake of K1 is about 10 times higher than dietary intake of K2. K2 intake in the United States is mostly from dairy. On the test here, we're measuring MK7, menaquinone 7. K1 is converted to K2. It's somewhat inefficient process, but happily K2 is also synthesized by gut bacteria. So when you see, and in this instance, you have a deficient K1 white blood cell and or borderline deficient, and then you have a grossly deficient K2 white blood cell. So they really don't have, this person really didn't have enough white blood cell vitamin K1 to convert it to K2, but it's even, farther disagreement here. I mean, it's less than the limit of detection. So I would actually say, maybe they're one, just not getting enough K from their diet, but two, I would rule out that there's some type of, gut dysbiosis. Why, is K2 not being synthesized, in the gut? Or maybe they have bile acid insufficiency. So, a gut zoomer would be nice to really help assess, is there any gut dysbiosis or bile acid insufficiency? I'd also want to highlight for abnormalities, branched chain amino acids. Less commonly, you'll see this, but it's very clinically important, significant when you do see, and in the picture, we're really not seeing it here, but I wanted to highlight you can have high branched chain amino acids here for these results. It's not. Sometimes you'll see isoleucine, valine, or leucine up around like that 80th percentile or 90th percentile, really approaching borderline high in the red. In those instances, you really want to consider getting a glycemic control workup. High branched chain amino acids correlate with insulin resistance. The mechanisms are still under research. But I definitely recommend getting a hemoglobin A1C, a glycated serum protein, a fasting insulin, and really just understanding, is this, associated with insulin resistance? Of course, you also want to rule out that they're just taking a branched chain amino acid supplement, or many protein powders that are higher in leucine, like your whey, your soy, your pea protein, et cetera. But it's a lesser known relationship that definitely deserves workup. And we're just about out of time. I did just want to highlight on our omega-3 fatty acid panel. We don't want to just look at their kind of dietary intake or supplemental intake of omega-3s or omega-6s. We really want to understand along the pathways if they have any impairment in their enzymatic activity. So, EPA is converted to DPA by the elongase enzyme. Those enzyme cofactors B3, B5, B6, biotin, vitamin C. So sometimes you may see a higher, very strong EPA, and then maybe like a midpoint DPA, and then like a low DHA. And in that instance, I'm saying, they've got adequate EPA, but they're not converting it to DPA or DHA. Is this really what may be inhibiting, the enzymatic activity? DPA is converted to DHA with delta-4 desaturase. Again, you have numerous enzyme cofactors. And other things that can inhibit the enzyme activity are like trans fatty acids, saturated fats, excessive alcohol intake can all inhibit delta desaturase, desaturase enzymes. You have delta-4, delta-5, and delta-6 in that pathway. So those are some things that can inhibit the enzymatic activity. Okay, so for your omega-6 fatty acids, and I think an earlier speaker had kind of spoken to the inflammation or anti-inflammatory nature of, the fatty acids, of course. But for omega-6, linoleic acid is converted to GLA, then DGLA, then arachidonic acid. We're giving a nice snapshot of omega-6 fatty acid here. We don't report on GLA or DGLA, but you do have enzyme cofactors involved each step of the way. And those enzyme cofactors are B2, B3, B5, B6, biotin, vitamin C, and magnesium and zinc. Again, you have the same inhibitors that can inhibit the enzyme activity. So, again, you always want to kind of consider, if we've got enough of, like here, linoleic acid, being converted to arachidonic acid, is there somewhere along the way that the enzyme activity is, impaired because of micronutrient cofactor insufficiency or deficiency, or some of these kind of inhibitors, also dietary related, of course. So leading to, higher levels of arachidonic acid, which then leads to higher levels of prostaglandin E2 and the 4-series leukotrienes, both of which are so inflammatory. So this is actually a pretty standard omega-6 fatty acid results that you'll see for most of your patients. Often the omega-6 fatty acids are up there around the 70th, 80th percentile. Actually here, the linoleic acid is very favorably low and uncommonly low. Usually it's going to be, you know, right up here approaching the red, somewhere around that 75th to 80th percentile. So that's just kind of a snapshot of a few patterns that you might commonly see. I'm happy to take any questions.